Good morning, everyone, and I'd like to thank the organizing committee for inviting me to give this talk, which has raised a lot of controversy recently, and hopefully by the end of my talk, I'll have some answers based on recent randomized data and published guidelines. So what is the rationale for dual antiplatelet therapy? One is to decrease the risk of thrombosis related to the stent procedure itself, either early, late, or very late stent thrombosis. And the second is the potential for a systemic benefit of DAPT that extends beyond the stented segment to the remaining coronary vasculature, possibly reducing future coronary events. Now, this is the 2011 ACC FHA SKY guidelines for PCI, and it basically recommended 12 months of dual antiplatelet therapy for all patients who have drug-eluting stents, whether it was in the setting of ACS or elective. And this was based on data from CURE PCI and also from observational studies in the first generation drug-eluting stent era that showed increased risk of thrombosis. So first generation era, everybody was receiving 12 months of DAPT regardless of presentation. However, there were concerns about the negative outcomes of bleeding overall in the outcomes of PCI. And along with the development of safer, less thrombogenic second-generation drug-eluting stents, interest is created in revisiting the duration of DAPT, going back to maybe a shorter duration, as was with the initial recommendations for Taxus and Cypher stents of 3 to 6 months. So the optimal duration of antiplatelet therapy, dual antiplatelet therapy, after second generation drug-eluting stent implantation remains uncertain. And the second question is the role of prolonged therapy in stable post-myocardial infarction patients. So the right balance would be to find the minimum duration of DAPT to prevent stent-related thrombosis. So basically, you're giving DAPT here to prevent stent-related complications. And identifying patients who benefit from prolonged, meaning more than 12-month DAPT duration with an acceptable bleeding risk. So the data I'm about to show has been released over the last 5 years, and it comes from 11 randomized control trials, and mostly involving second-generation drug-eluting stents. 5 trials compared shorter duration DAPT, 3 to 6 months, versus standard therapy, which was considered 12 months. And a total of 6 trials compared prolonged DAPT, 18 to 48 months, versus standard therapy, which was 12 months. So I'm going to start with the trials that looked at shorter duration DAPT in drug-eluting stent patients. A total of 6 trials were conducted, and these were all mostly in low-risk patients, mostly non-ACS, and they mostly included second-generation drug-eluting stents. And all studies, all of them, that compared shorter duration to standard duration showed non-inferiority of shorter duration. There's the excellent trial, which showed compared 6 to 12 months, reset 3 to 12 months, optimized 3 to 12 months, security, eyes are safe, 6 to 12 months. All of them showed no benefit of going to 12 months in stable PCI patients. So how about prolonged therapy beyond 1 year compared to standard therapy? And here, this was evaluated by 6 trials, comparing 12 versus 36 in the DS Late, 6 to 24 in Prodigy, 12 to 18 in Arctic, and Italic 6 to 24. And last but not least, and I'll spend more time on this trial, the DAPT trial, which was 12 versus 30 months. Now, apart from the DAPT trial, all these studies failed to show superiority in prolonging DAPT therapy beyond 1 year in terms of cardiac death, MI, stroke, TVR, and also were shown to increase the risk of major bleeding. So how is DAPT different? DAPT was released in New England Journal in December 2014, and they compared 12 to 30 months of dual antiplatelet therapy with drug-eluting stents. This was the largest trial to compare standard therapy versus prolonged therapy. 9,000 patients were included, and this was the only trial that was really powered to show any statistical benefit in terms of mortality or hard outcomes. Again, most of these patients had second-generation drug-eluting stents. If you look at the first graph, you can see that stent thrombosis was decreased with prolonging dual antiplatelet therapy beyond 12 months. So all these events are events after the first 12 months of dual antiplatelet therapy. Patients who had events in the first year were excluded from randomization. Also, MACE was decreased from 12 to 33 months in patients who received prolonged dual antiplatelet therapy. So what's the price? The price is really an increase in bleeding. Although gusto-severe bleeding was not increased, the combination of gusto-severe or moderate bleeding was increased. So definitely there is a bleeding risk associated with prolonged therapy, and that should be taken into consideration when deciding on when to stop dual antiplatelets. So the conclusion of the DAPT trial was, among patients treated with DES, continuation of therapy beyond 12 months reduces ischemic events. The reduction was consistent across stent type and thyroidine type, and was evident regardless of the risk of stent thrombosis. However, this clinical benefit came at the expense of increased bleeding. So what is the answer? How do we address this? So based on the shorter duration trials, which included stable ischemic heart disease patients, the recommendations have been to stop dual antiplatelet therapies at 6 months. ACS patients are treated differently. They should all be receiving 12 months, a minimum of 12 months of dual antiplatelet therapy. And continuation beyond 12 months really requires risk-benefit assessment. Now, how do we come by this risk-benefit assessment? Do we have tools? Do we know data? And looking at this table, you can identify patients who are increased ischemic risk or increased risk of stent thrombosis, age, ACS presentation, diabetes, poor EF, stent undersizing, stent underdeployment, small stent diameter, and complex bifurcation disease. All these increase your risk of ischemic events. Now, what are the risk factors for increased bleeding risk? History of prior bleeding being the most important one, oral anticoagulant therapy, female sex, advanced age, low body weight, chronic kidney disease, anemia, and chronic steroid or NSAID therapy. And it's this particular group of patients where you really have to be very careful and have to have good reason to extend therapy beyond 12 months. So this was put into a scoring system, which I think will help
Dr.
us
Amr?
come
Dr.
up with decisions on whether to extend beyond 12 months or not. And the DAPT score is based on nine variables: age, current cigarette smoking status, diabetes, ACS at presentation, prior PCI or MI, small stents, paclitaxel eluting stents, low EF, and saphenous vein graft PCI. And all these are weighted differently. You can see that the greatest impact is on those patients with CHF or low ejection fraction and saphenous vein PCI getting 2 points. The higher the points, the more benefit there is from prolonging therapy beyond 12 months. So, and the cutoff is really 2 points. So anything 2 points and above, in the absence of a strong contraindication to continue DAPT, is probably a good reason to prolong therapy beyond 12 months. And just to summarize, this is the recent focused update on duration of dual antiplatelet therapy by the ACC and AHA. And all that's in green are class 1 recommendations. So for stable ischemic heart disease, DES therapy should be at least 6 months. Continuation beyond 6 months or stopping before 6 months was given class 2B indications and should be based on the risk-benefit of bleeding versus thrombosis. Bare metal stents, class 1, 4 weeks. Extending beyond that, you need justification. If you go to the ACS population, all patients should receive at least 1 year of dual antiplatelet therapy. The question becomes, what do you do after that 1 year? And after that 1 year, you really have to make a conscious decision of whether the patient is going to benefit from prolonging DAPT or is probably going to benefit from just staying with single antiplatelet agents. And the DAPT score can help you with that. Any deviation from this class 1 recommendation, going above 12 months or less than 12 months, is class 2B and needs a very careful thought. Thank you.